Good morning to one and all. Myself, Dr. Archana Khare, welcome you all on the behalf of my team to the most awaited event of the year, the prestigious Dr. V.N. Shirodkar Oration. Dr. Shirodkar, a stalwart in his field, has established a legacy, which we are fortunate enough to enjoy and follow. Every year, this oration is presented to the distinguished individual who have made outstanding contribution to the field of OBGY. And this year, too, we have an orator of an outstanding stature to address this august gathering. Now I request Dr. Anjali Jamma ma'am, please escort our guest orator Dr. Ashwat Kumar sir on a dais. I invite our upcoming president, Dr. Vivek Virkar sir on dais. I request Dr. Supriya Jadhav and Dr. Monica Umbardan on dais. Saraswati, the goddess of knowledge and arts, represents the free flow of wisdom and consciousness. She is the mother of Vedas and chants to her called Saraswati Vandana, often begins and ends Vedic lessons. I invite Dr. Supriya Jadhav for Saraswati Vandana.
Thank you, Archana. ज्ञान ज्याला उगम नव्हता, ज्याला अंत नाही. ज्ञान ही काही अनुवंशिकरित्या मिळणारी कोणती गोष्ट नाही. आपल्या दैनंदिन अनुभवातून रोज नवनवीन गोष्टी शिकून मिळवलेली ती अजिंक्य संपत्ती आहे. तर आज आपण आपल्या शुभ कार्याची सुरुवात या ज्ञानाच्या देवतेला सरस्वती मातेला वंदन करून करूया. या कुंदेन्तु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिर्देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा. शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाढ्यान्धकारापहा. हस्ते स्फाटिकमालिका विदधतीं पद्मासने संस्थितां वन्दे तमपरमेश्वरीं भगवतीं बुद्धिप्रदां शारदां बुद्धिप्रदां शारदां बुद्धिप्रदां शारदां. Thank you.
Dr. Supriya for a melodious and very peaceful Saraswati Vandana. Now I request Dr. Anjali Jamma ma'am to present the preamble.
A very good morning, esteemed speaker, seniors, teachers, and my dear friends. It is my proud privilege and honor to welcome you all for this most awaited occasion of the year in honor of the legendary figure late Dr. V.N. Shirodkar. Dr. Shirodkar is a well recognized and internationally famous for his pioneering work in the field of infertility, reproduction, and also innovation in operative techniques for different surgeries. To name a few, Shirodkar sling operation for prolapse, cervical cerclage, tuboplasty, and family planning. People used to come from all over the world to watch him operate and used to admire his operating skills. He had many awards to his credit like Padma Bhushan, Padma Vibhushan. In the remembrance of Dr. Shirodkar, and to engrave and continue the medical education and form a stronger union of SOGS members, our seniors decided to start this great tradition of Shirodkar Oration. In the era of paucity of communication, transport, funds, they have started the oration in 1989 in the tenure of Dr. Ajit Kulkarni sir. The very first oration was given by renowned speaker Dr. Das Gupta, who delivered speech on pregnancy-induced hypertension. Our members were mesmerized with his exhaustive talk. In last 35 years, SOGS has invited many stalwarts from all over the country to upgrade our members with recent advances. This year, we are fortunate to have a great orator and extraordinary academician, Dr. Ashad Kumar sir, to sail us through this journey of the life with PCOS from womb to tomb. PCOS is a widely discussed topic and yet is an enigma. Ashwath is a tree under which Gautam Buddha gained enlightenment. I am sure Dr. Ashwath Kumar, true to his name, will definitely enlighten us on PCOS. Thank you.
Thank you, ma'am. Now I request Dr. Vivek Virkar sir to present life sketch of late Dr. V.N. Shirodkar.
Presentation,
Good morning, one and all, respected dignitaries on the dais and off dais, teachers, seniors, and my dear friends. It is a great honor for me to present the life sketch of the great innovator, visionary, hard worker, late Dr. V.N. Shirodkar. Dr. Jonas Salk said that there is a hope in dreams, imagination, and courage of those who wish to make these dreams a reality. This is really true for Dr. Shirodkar. Dr. Vitthal Nagesh Shirodkar was born on 27th April 1899 in Shiroda, a beautiful village in Goa. He completed his education from Hubli, Karnataka. He graduated from one of the best medical colleges of India, Grant Medical College, Mumbai, in 1923 and completed his MD in obstetrics and gynecology, after which he went to United Kingdoms in 1931 and did his fellowship from Royal College of Surgeons. He returned to India in 1935 and joined the JJ Group of Hospitals as an honorary obstetrician and gynecologist. Dr. Shirodkar was an inimitable teacher, working tirelessly and captivating his student with his knowledge and experiences. He is remembered with affection and gratitude among his students. He had an innovative and imaginative mind, which gave birth to interesting concept of incompetent service being the cause for the second trimester abortion. He was particularly interested in the changing nature of the cervix during pregnancy from fibrous to the dynamic muscular organ, and which was the origin for his own developed method of surgery. And this original surgery was a masterpiece and an outstanding contribution to the history of obstetrics. In 1951, at an international conference at Paris, he thundered that no woman should lose her precious baby because of cervical incompetence, and he gave the world a totally different and innovative surgical approach for cervical incompetence, describing it as a cervical encerclage operation. This operation has now been accepted by whole world and named deservedly Shirodkar's encerclage operation, which latter described at Naples in 1956. Dr. Shirodkar traveled all over the world and demonstrated his technique with colored slides and films, and also he developed surgical instruments for the same. He also came up with new procedures for many other gynecological conditions, most famously the two surgeries for the genital prolapse, that is Shirodkar extended Manchester operation and Shirodkar sling operation for prolapse. His views on the genital prolapse are found in the chapters in the advances in OBGYN by Marcus and Marcus. Among many students, I have been very fortunate to see all these operations and bring them into practice, like I always love to do Shirodkar extended Manchester in young patients with prolapse. He carefully studied the anatomy and physiology of the genital system, and he had a passionate zeal to improve the results of tuboplasty and for the creation of new vagina in vaginal agenesis patient. Dr. Shirodkar wrote in the preface to his monograph, "With all due respects to the old masters, I did not reconcile myself to some of the operative procedures which fell far short of the ideal, and ideas come to my mind for improving the same time-honored methods." He was a surgeon with a unique operational skill set and a sharp, quick mind, and helping him to be so precise in his work. He published his contribution to the obstetrics and gynecology and also wrote chapters about his views in volumes 4th, Meigs and Stargis. Indira Gandhi delivered Rajiv Gandhi under Dr. Shirodkar's care, as he was a well-known international figure. Apart from academics and surgical interest, he was an accomplished violinist and a fond interest in painting and sports. One of our relatives, Mr. Gangadhar Sate, staying at Thane, worked as a chartered accountant for Shirodkar. For many years, when he came to know that I am presenting a life sketch of Dr. Shirodkar, 93 years old Mr. Sate sent me his feeling about Shirodkar. मी पाहिलेले डॉक्टर शिरोडकर घरातले, and told many things on phone. I don't want to go into details, but one interesting thing stuck in my mind. He was doing ENT surgery before becoming a famous gynecologist, and Mr. Sate was one of the tonsillectomy patient. Also, notably, despite being tireless practitioner, he always took keen interest in social medicine. He was member of Shantilal Shah Committee on Abortion and was of the view that the indications of abortion should be liberalized in our country. He took active interest in family planning programs of the country and was a member of many official bodies. Honors were bestowed upon him by many institutes and countries. The President of India awarded him Padma Bhushan in 1960 and Padma Vibhushan in 1971. Dr. Shirodkar was a gifted son of India, such a great man, thinker, innovator, teacher, surgeon par excellence. This multifaceted, knowledgeable human being left this world with his blessing upon us on 7th March 1971 in Mumbai. So we all salute him as a pioneer in experimental surgery and gynecology. Thank you.
For your wonderful presentation. हम रोज़ भगवान के सामने दीप जलाते हैं ताकि भगवान के बहाने हम अपने आप को देख सकें कि हमारी ज़िंदगी का स्वरूप ऐसा होना चाहिए जैसे कि दीपक का है। रोशनी जो हमें दीपक से मिलती है, रोशनी माने जीवन। रोशनी कैसी? जैसे दीपक की, बिजली की। रोशनी से हमारा मतलब है तमसो माँ ज्योतिर्गमय, यानी हमें अंधकार से प्रकाश की ओर लेकर चलिए। अब यह प्रकाश है ज्ञान का। दीपक हम जलाते हैं तो इसका मतलब यह है कि हमारा मस्तिष्क ज्ञान से भरा हुआ हो, विचारणा से भरा हुआ हो, प्रज्ञा से भरा हुआ हो। दीप प्रज्वलन का अर्थ है रोशनी भरा जीवन। व्यासपीठ पर उपस्थित सब आदरणीय डॉक्टर, मेरे सहकारी, मैं इनको आमंत्रित करती हूँ दीप प्रज्वलन के लिए। और हम आज डॉक्टर वीएन शिरोडकर इनको श्रद्धांजलि अर्पण करते हैं।
शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः। शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः। शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते। दीपज्योतिर्नमोऽस्तु ते। दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः। दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः। दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते। ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः। ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः।
I thank all the dignitaries on dais from bottom of my heart and request to please take the seats.
ज्योतिषां प्रभुरव्ययः। आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा। रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत्। रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत्। यस्य तिष्ठेत् गृहे दीपः तस्य न।
Thank you all the dignitaries on dais from bottom of my heart. I request to please take the seats. Now I request Anjali Jamma ma'am to please welcome our today's speaker, Dr. Ashwath Kumar sir. फायनल नाही.
अनाउन्स करेल डायरेक्ट.
Now I request Dr. Anjali Jamma ma'am and Dr. Manik Gurram sir to chair the oration. Dr. Anjali Jamma ma'am, she is President SOGS, consultant at Jamma Hospital. She is practicing cosmetic gynecology and she is first who started laser in gynec practice in Solapur. Dr. Manik Gurram sir, past President SOGS, Director at Markandeya Rugnalay Solapur, consultant at Ankur Nursing Home. He is expert in NDVH surgeries and conducted many workshops in the part of India on NDVH. Welcome Dr. Anjali ma'am, Dr. Gurram sir. Now I request Dr. Manik Gurram sir to introduce our today's speaker for the oration, Dr. Ashwath Kumar sir.
Good morning. It's my privilege to introduce an extraordinary person. If I introduce him in regular format, these are the two slides, but we will see him in a different way. Dr. Ashwath's primary schooling at Holy Family English Medium School at Thrissur. And recently he got the best student from that school till date, and there he was felicitated. Then he is MBBS from Thrissur Medical College. This is the Thrissur Medical College. Then MD from BJ Medical College, Ahmedabad. Working as a professor of OBGYN at this Jubilee Mission Medical College and Research Institute. Keen interest in laparoscopy. He did FICOG diploma in advanced laparoscopy at France. Then a diploma in laparoscopic management of advanced endometriosis in Austria. Diploma in laparoscopic management of gynec malignancies. And also authored around 15 books and many publications. A Foxy Vice President 2019, very active in Foxy. Felicitated at Foxy at many times. Felicitated at Foxy many times and did live laparoscopic workshops in various AICOG conferences. Also active IAGE office bearer. In IAGE Governing Council member 2021 to 23, IAGE Managing Committee member 2021 to 2023. Always mingle with friends at conferences. And our Solapurian Sandesh is there with him. Current president of All Kerala Federation of Obstetrics and Gynecology, and theme for this year was Reach Out. He is active not only in academics, but also keen to play roles in various kits for education of the people. A very true family person. Both parents are teachers, and now his son is on his path, doing MBBS first year. A very travel lover, ardent sports person, plays table tennis at state level, and last year he got the runner-up prize. And now he is playing with his son at various matches. Yes. As he is from Kerala, football is in blood. You can see he and his son at football matches. And cricket also. You can see how keenly he is looking to Bradley and listening what he is saying. Also watch movies and enjoys with children. An artist, a true nature lover. Out of many facets of his life, one important factor is he lives life as per his name. And that is Ashwattu Ennala Dronacharya, meaning Ashwat meaning Dronacharya. Ashwatu enala alaram. That meaning is a banyan tree. So this is a banyan tree where Buddha did medicine, as Jamma already told, and get lot of knowledge. So it can also be considered him as a tree of knowledge. There are so many students who got post-graduation because of him and passed post-graduation because of him, and he practicing all over the India. These are the glimpses of few such incidents. A DMB training online, talking with its students who got All India PG rank 1, and education on YouTube. But here we can say how he admired by his student. A true modern Dronacharya, offline and online. I am sure even he feels satisfied more by love from his students and also his love for teaching, which he inherited from his parents. Now here is another identity of him. Till this is completed, I will request to take the podium. Please. Thank you, sir.
Final. That's it. First of all, I'm so thankful to Solapur Society for inviting me for this prestigious oration. So thank many people of that President Dr. Anjali, Dr. Archana, Secretary, Dr. Supriya, Clinical Secretary, and Dr. Monica. Actually, to really telling you that I tried to avoid, it was on 15th. Actually, initially it was kept. So we have the Vishu, that means our festival. So the travel, thinking of the travel, I told that I may not be able to come. Suddenly they shifted it to 9th. So I didn't have, so for you we are shifting to 9th, they told. So I didn't have any option to come. I'm knowing many of the Solapur, many of you for a long time, like Milan sir for last maybe 20 years in Foxy. So many people, Sandesh, operate along with Sandesh in almost all the conferences. So he has come to my house in, maybe he is not there, out of station now. That is why he is not here. Anyway, it's always a great privilege to be having an oration in the name of V.N. Shirodkar. Imagine every day we talk about them. At least every week we do Shirodkar surgeries for cerclages. Some operations, some instruments, and we know many of these instruments, even you may not, many of you don't have, I have this instrument actually. Can you have a pointer if it is there? If it is there, it's okay. Pointer. So this instrument, even many of you seniors may be having, this is for cerclage actually. It's a, whenever you have, sometimes there was a time when we only used to, if Marceline tape with the needle is very costly. Okay, so they increase the cost. So I told that, then I checked in my, because my hospital is 50 years old actually. So 75 years, so I checked, went to the room and checked all the instruments. I got this instrument. Now I use only that Marceline tape, cut the both ends of the Marceline tape attached to this and then pull it like this. Then into that you keep. So Marceline tape is cheap. Marceline tape, not the mesh is cheap. Okay, that tape. Otherwise, with the needle, it is now the Johnson & Johnson have increases to too costly. It is actually from 1,500, they have to increase to 6,500. So all these things, I'm fascinated with all these instruments. So, and all about him you heard. So about all these things, and to give an oration in the name of V.N. Shirodkar is such a privilege for me. And Kara sir had done more homework than I have done for PCOS today. So I was so fascinated. The whole Facebook you would have searched to get all this. Thank you to the latest. Last week only I got that praise of. So that also included. Thank you so much, all my students. Being, as he correctly told, why I became a doctor, actually, I never wanted to become a doctor. I wanted to become only a teacher. So in 11th, maybe the son of a teacher, both parents were teachers, I was studying well in the class and got good marks, getting good marks in the class. So they wanted me to become a doctor. So I wanted to become only a history teacher. I was fond of traveling, reading history, and that was what a school teacher, history, and I want to teach. But one day my father told me that, 11th standard, he told me, you find the meaning of doctor and come back. So I went searched and found to teach it was. So he only the person who told that even if you take a medical profession, you can become a teacher. That is how I never, even if my practice increased, I never wanted to leave the medical college setup and to teach. Teaching is my passion. Whatever time it is, morning, evening, to teach students is, unless I take students, I don't leave them at all. Whatever time they will be, but they enjoy with me teaching, so I also enjoy. Many times they say that other faculty say that don't bore them with your classes. Too much is too much, even if it's Amrit, if it is too much, it will be harmful for them. Okay, anyway, we come back to our topic. About the topic which I told when oration was told. I wanted, initially I thought of, because I do different techniques of circlage and all new technique I have published. So I thought I will do something in obstetrics and all. Then I thought something which should be useful for everybody. Infertility, everyone, without this, managing PCOS is managed by everybody. So this is what I thought will take a topic on PCOS. Then I thought what to learn. Initially I termed it as PCOS and infertility. Then I thought it will be only useful for infertility people, something new. So next 40-45 minutes we will have from womb to tomb. Story of my patient is Miss Dolly, who lived with enigmatic poly, that is PCOS. So coming to see, if you see, the PCOS or the polycystic ovarian syndrome or the disease, it's prevalent all over the world, but its presentation is different in different parts of the world. So if you see this picture, you can see the world distribution. If the PCOS in India presents with extremes of metabolic disorders, in another place it presents with hyperandrogenism, another place it presents with ovulatory dysfunction. Different parts of the world it presents differently. Coming to epidemiology, you can see here 20 to 33% of the reproductive age group have PCO. Imagine 5 to 10% have PCOS syndrome with all features. 87% of women with have oligomenorrhea, 26% have amenorrhea of PCOS, 50% of land up with infertility, 50% of women who become pregnant can have miscarriages and abortions, and 50% who become pregnant will have pregnancy complications. So imagine, whatever it is, even if you treat, it goes on like that. Is it have an inheritance? No clear inheritance, mode, cut mode. Initial studies such X-linked, then recent studies say autosomal dominant. But one thing is sure. So this is the importance of family history. Whenever a patient comes with PCOS, you just ask, you have siblings, 40% if the sister is affected and 10% if the mother is affected. Different genetic studies. One classical study is called candidate gene study involved. They showed that it can affect steroid hormone synthesis, carbohydrate metabolism, gene involved in gonadotropic actions, but no karyotypic abnormality was found in that study. Then came the genome-wide association study. We'll come to the practical points just to know that it has a genetic basis. So they found out about 16 robust genes locate for PCOS. What is the importance? See, we are going to the next generation. That is what we call as gene mapping. So, if by gene mapping, if we are able to find the correct loci and the pathway, and the pathogenesis can be found out, and then we will be able to find the cause and the treatment for it. So, we have an underlying genetic factor. Swing-Bird's specific gene not determined. Many candidate genes have implicated. Different combination of multiple gene polymorphism and environmental factors explain the heterogeneity of PCOS. See, this is why you ask many times, why it is prevalent in my seniors sitting there. When we were MBBS students, we never saw PCOS. Now, why it is too common? And all these things are usual things. Usual, whenever we meet, they say that, okay, when we were MBBS in 1980s, no PCOS was there and all. So, it's all here. Your environmental toxins, pollution, diet and nutrition, geography. See, I told you, physical geographical determinants like climate, terrain, latitude, longitude, everything changes. And it's not that the high socioeconomic status, it's a low socioeconomic status people many times more affected because of the increased carbohydrate. If you see, in my house, a maid, when we give in the afternoon, she takes this much rice and little curry. How much I might say, and she is diabetic also, she has all problems, metabolic syndrome, everything is there. In between, she becomes faints and we have to take her to the hospital. These are things routinely going on. So, PCOS, don't think that it is a disease of high socioeconomic status. Everybody listen here, this is a new theory. Developmental programming and transgenerational transmission. See, olden days, there were something like hunter-gatherers they were. Okay. All these things were there, but these were all physiological. You see, insulin resistance was to increase blood sugar during starvation. Hyperandrogenism was to increase the strength and fitness. Enhance energy storage to survival chances, and there was decreased fertility that was also for the survival chances. But it was called the adaptive survival response. Okay, what has happened now? It is maladaptive survival response. Here the insulin resistance leading to PCOS and metabolic syndrome, hyperandrogenism leading to acne, hirsutism and metabolic problems, enhanced energy storage leading to obesity and metabolic disease, and decreased fertility leading to infertility treatment. See, this is a new theory which everybody should, just to know that these are the new things which are in them. Now coming to what is the prevalence, okay. You imagine it's the most common endocrine disorder. So, when you were in PG entrance questions, they ask which is the most common endocrine disorder, it's a PCOS. And prevalence, if you depend upon the population, 6.3% of the South Asian, 4.8% of the Caucasian, 8% of the African, and 2.2% of the Chinese people population have PCOS. And if you have different types of criteria, depending upon the criteria, based on which criteria you study the PCOS, NIH, the old criteria 8.7, but Rotterdam included everything. That is why 18% of the population has PCOS. And Androgen Excess Society, 12%. We will come to it. Now we come to our story. A PCOS mother delivered today morning at 9:49 a.m. a difficult cesarean, 4.8 kg baby girl. Now we are going to meet baby Dolly. So here, see, PCOS implications is not just a reproductive. Reproductive implications are there. It can come with menstrual disturbances, hirsutism, infertility, pregnancy complications, and gynecological endometrial cancers can be there. On the other side, metabolic obesity, hyperlipidemia, type 2 diabetes, cardiovascular disease, psychological, body image, self-esteem, mood disorders, depression, anxiety. As the mother of Dolly was having PCOS, so the doctor, myself, we counseled her, explained in detail to the parents of the baby Dolly about implications of PCOS and need for a healthy lifestyle and to keep a regular follow-up, please. But as usual, nothing happened. Miss Dolly kept growing without any care. Okay, finally she is in front of you. After her mother was your patient, she is in front of you asking you, doctor, I am stressed, lot of facial hair, scars, head hair, and having acne. I am a bit too much for the weight for a 15-year-old. Back of my neck color is there, maybe acanthosis. And well, don't get my periods on time. This is what all these things she is asking. So, when you say diagnosis of PCOS, okay, it has a central diagnostic features and different types of classifications. So you have central diagnosis is the simplest slide which I can have. Hyperandrogenemia or hyperandrogenism, oligo-ovulation and polycystic ovaries. Naturally, everybody knows this. Now we will take one by one. So to say that what do you see, simple terms, an enlarged ovary, large number of follicles, peripherally arranged and a echogenic bright stroma. This is the basic. But I am all telling you because the latest PCOS guidelines, okay? So I want here to know the latest advancements and latest guidelines, what changes have occurred. To say it's a PCOS, see, you should have a TVS probe with a frequency of more than 8 or 8 megahertz. And a follicle number per ovary, it's called FNPO. All the infertility specialists, they use FNPO, FNPO. FNPO should be more than 20. Previously, it was to teach students, it was 10. See, we used to say more than 10 follicles, less than 10 millimeter, more than 10 ml volume. See, it was very easy. Now, it has slightly changed. The FNPO, today onwards, it's more than 20. Some people say for adolescents, it's more than 24. So, and you have to ensure that there should not be any corpus lutea, cyst or dominant follicle. When you are reporting, it should be clear. So, how do you report? So, these are different types of inversion mode grid system. So many nice volume you can calculate 2D, 3D, but 2D is enough for the diagnosis of reporting. See, how do you report, everybody? See, a report, a good report should have, what are things a good report should have? Last menstrual period, transducer bandwidth, I told 8 megahertz, transvaginal, follicle size should be 2.9 and it should be more than 20. 3-dimension, the volume of the ovary should be measured. Endometrium better measured in a trilaminar view. And ovarian and uterine pathology should be excluded. As well as ovarian cyst, corpus luteum and dominant follicle should not be there. So this is taken directly from the latest guidelines, okay. But to make for you people simple, see, this is what you people know. FNPO more than 20 if you are using a transvaginal scan with a 8 and 2D is enough, okay. Sometimes your scan machine may not be so much clarity will be there. Then you go transabdominally, then you cannot say FNPO. There you measure the ovarian volume and be satisfied with it. So, but the last sentence written is important. Now the latest guidelines and taken away 8 years post-menarche, you cannot use ultrasound to diagnose PCOS. All of you, the first point to learn today is that an adolescent girl coming with a report of PCOS, in a scan, PCOS morphology should not be considered as the diagnosis is the latest. So, two things which you learned extra are FNPO more than 20 and up to 8 years post-menarche, ultrasound has no value in diagnosis of PCOS. The commonest mistake you make is that all of you do scans. Nowadays, all gynecologists do scan. Most of us. So, multifollicular ovary gets confused with even a young radiologist who are not experienced will write PCOS for a multifollicular ovary. Two things only you have to remember. Number of FNPO may be more than 20, leave it. Normal stromal echogenicity. So you have the normal stromal echogenicity that less than the myometrium. Normal ovarian volume up to 10 and so the normal ovarian volume and the normal stromal echogenicity if it is there. How many number of follicles is there? No, that is the importance of looking into volume. Not only count only the follicles. So volume and stroma, that is a both thing. So usually, see, normal stroma means it should be, you compare with the myometrium, very easy actually. Normal stroma will be less than, the echogenicity will be less than the myometrium. Now, so all of you understood about, I hope that if you understood about PCOM, that the morphology you understood. Next important is hyperandrogenism. If I say it is one of the most important. Okay. Hyperandrogenism is by, what we say is the modified Ferryman-Galway scoring system more than, I will tell you, what is it, I will tell you all of you. 4 to 6 indicates hirsutism and only terminal hairs need to be counted. What do you mean by a terminal hair? Hair more than 5 millimeter it should be thick, it will be pigmented. Okay, it will be pigmented, thick, and it may come in clusters actually. It's a group. So terminal hairs should be only considered. So biochemically calculated, we calculate only the free testosterone level. See, you have different types of testosterone. Okay. Testosterone is there, 5-HT is there, DHEA is there, DHEA is there. Here we calculate only the whole is free testosterone is what is, because rest of it is bound to SHBG. That means serum hormone binding globulin. Okay. So the free is the only thing which is active. We don't test any type of testosterone. Don't test unnecessary DHEA, DHEAs and all these things. Only free testosterone should be tested. If free testosterone is normal and the patient is having hirsutism, then you think about other things. Okay, then you do other investigations. Do minimal. This is what is called a Ferryman-Galway scoring system. 9 sites have been taken and each site 0, 1, 2, 3, 4 is taken, and depending upon that it is all given in your books. Depending upon that it should be, if it is more than 4 to 6, it say that patient is having hirsutism. So in general, hyperandrogenism means Freeman-Galway scoring system more, that is for hirsutism. Comedone acne. See, all of you, clinical point is that acne of PCOS will be here. This area, lower part, acne in the lower part, and acne of PCOS will have comedones, dots, comedone acne. So it's simple, if it is here, don't bother. Classically, it is in the lower jaw, acne this side, that is what if it comes, and Ludwig visual score for alopecia. About testosterone estimation, all of you please listen to this. Point is that, see, there are different types of assay. Tomorrow itself you ask your lab in which it is done, what is the way which many places they do ELISA and all that is of useless. Then don't do free testosterone level at all. Okay, so if you are ask your lab that you are doing liquid chromatography, mass spectrometry or extraction, many of the labs have. Now the best labs have. Don't go to local labs for all these things. Direct free testosterone assays such as radiometric or ELISA and all these things are not useful. So I will give you simple tips. These are practical points. Free testosterone, if you want to estimate, good lab, upper limit is same as adults and adolescents is the same. 40 to 60, if it is the nanograms per deciliter, it is 40 to 60. Nanomoles, it is 1.4 to 2.1. PCOS, it can go up to 150. If your free testosterone level is more than 150, that's the most important point. If it goes more than 150, then you think about any virilizing tumors. Then you have to do all the other tests. Do at 8 a.m. Maybe many of you don't know, that is why. Best between 4th day to 6th, 10th day of cycle, it decreases in the afternoon. So don't say that, and doubles in the mid-cycle. So you have to see, that is why 4 to 10 days of the cycle. And very important is that you have to stop OC pills for 2 to 3 cycles before doing testosterone. Otherwise, OC pills increases SHBG. Naturally, your testosterone will come down. Free testosterone levels will come down. This is not, you will not get in books. This is the practical thing which I have written here. This you will not get anywhere. So this is just to, so some points to take home. So in the first, when you take morphology, you took 2 points home. You got FNPO and you got to how to differentiate between a multicystic ovary and these are the 2 things you learn. Coming to the third part, that is irregular periods. See, to know a period is irregular, you should know what is an irregular period. So first year post menarche after, don't, any patient comes, you will not say regular periods, it will be irregular. So after that, 1 to 3 years, you can see clearly here, less than 21, more than 45. 3 years post menarche, less than 21, more than 35, or there is only less than 8 cycles per year. See, less than 8 cycles per year. 1 year post-menarche, more than 90 days. See, if there is one cycle of more than 90 days, for example, patient is not ovulating, menstruating for 3 months. That is abnormal. Okay. So remember like that. So this is, and amenorrhea that 15 years the period has not come, or post-thelarchy after 3 years also the period has. This is what is called an abnormal period, irregular period. So other than that definition, it doesn't come into fit into anything. Now we come to very important thing for you to learn something new. See, we started with NIH criteria, Rotterdam, Androgen Access Society, and now we have an international guidelines. All my talk is based on the international guidelines of PCOS latest. Many of you may not have read. NIH 1990, maybe ultrasound was not popular at that time. So they did not have ultrasound criteria at all. They only had hyperandrogenism and oligovulation. Okay. When it came to Rotterdam, they took everything and they told that all the 3 we are taking, any of the 2 is positive, you label it as PCOS. That is why if you go by Rotterdam criteria, large number of patients diagnosed as PCOS will increase like anything. Okay, that is why we now, Androgen Access Society, naturally they say that androgen is increased, Androgen Access Society, androgen, hyperandrogenemia being the main criteria, and other 2, plus or minus other 2 being the. And we came to the latest international guidelines, where we told that all the 3 we consider, but we inferior consideration to the PCOM morphology. So many of you thought that most of the time we consider scan report and say that label this patient as PCOS. So what is the adolescent problems? Okay, in an adolescent, what are the problems? In an adolescent, if you take 85% of cycles are anovulatory in the first cycle, all the 3 criteria are considered, but 3rd criteria for the first 8 years is not considered. So that is what the take-home message for you. So 2 things, FNPO, and the second take-home message is, don't use today onwards, don't use ultrasound picture as the criteria. You can add to it. You have a hyperandrogenism, you can see the scan. You have in menstrual irregularity, you can see the scan. But don't take it as alone as a criteria. If a patient has a family history of PCOS with history of hyperandrogenemia, and you can diagnose PCOS. So in adolescence, this is another slide which I have made for you. Adolescence, USG is neither recommended nor required for diagnosis of PCOS. Okay. Both PCOM, if a patient comes with a scan, okay, PCOM, a scan is there. So careful follow-up, as at risk of menstrual abnormalities plus is there, you have to follow up it. See, don't leave that, don't label them as PCOS, but you have to follow them up if she has associated menstrual irregularity. Lack of hyperandrogenism rules out diagnosis. So in adolescence, everybody here, in adolescence, one thing, if there is no features of hyperandrogenism, you today onwards, you are not going to label a patient for as PCOS. Okay. Then, not all patient with hirsutism is abnormal, we will come to it. Mild hirsutism is there, okay. And if it is progressing, or if it is associated with abnormality, then you reevaluate for PCOS. Menstrual irregularity alone, we don't have not much concern unless it is, but you have to follow up. In an adolescent, obesity and insulin resistant, not essential for the diagnosis of PCOS. So PCOS in adolescent is hyperandrogenism, irregular periods, no USG morphology. So hyperandrogenism is the main catching feature in an adolescent. That is what you learn. Now come to something different. Okay, all of you, this is another thing to learn. See, I told you phenotypically in different parts of the world PCOS presents differently. Very important point. See, there are 4 types of phenotypes there in the world of PCOS. See, this is just to tell you that PCOS can present without morphological problems, PCOS can present without hyperandrogenemia, PCOS can present without ovulatory dysfunction. So, so you may ask me, why to complicate all these things? Why you want to know? There is some importance of knowing these 4 phenotypes. All of you learn HOPE, H-O-P, HOPE. Don't take E. HOP you learn. Hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. Okay, you learned like that. So if all the 3 are there, it is phenotype A. HOP is there, it is phenotype A. HO is only there, it is phenotype B. H and P is there, O is not there, it's phenotype C. And phenotype D means there is no hyperandrogenism. You understood? Okay. You understood? Everybody understood? HOP, I am teaching you very easily. So today onwards, somebody asks you, there are different phenotypes. Yes, there are phenotypes. Now you learn phenotypes, you learn now. You know ABCD. Now you have a question to me. Why you want to know the phenotype? So this is why you want to know the phenotypes. Okay. This is why. It's a small slide. I'm sorry for that because I wanted to conjust. See, don't read the slide at all. Those who are sitting behind, don't read the slide at all. You understand the basic thing is that A and B is considered to be the classic PCOS. That is the most common. Classic PCOS has all the features. Okay. B doesn't have, but it's a classic PCOS. Okay. Where the importance is that these patients are land up in metabolic syndrome. So if you are able to know the classic, and one more thing, classic PCOS have high levels of AMH. C and D may not have AMH. You come to C type, it is called ovulatory. That means ovulation is there. So everybody sitting here should keep in your mind PCOS can occur with ovulation. When you come to phenotype D, everybody should know that PCOS can occur without hyperandrogenism. Anybody has any doubt? So we have 4 phenotypes. So the importance is that most of the complications occur with phenotype A and B. That is what is called the classical. That is the reason why we want to know phenotypes. These are the latest things. Phenotypes, you have to know. The phenotypes has to be studied. So everybody understood? Everybody understood what is 4 phenotypes and what is the importance of phenotypes you understood. Okay, and you understood that PCOS can come with ovulation. So if the patient is ovulating does not mean that always it's not PCOS, and PCOS can come with hyperandrogenism. Now, this is, initially we all thought that for diagnosis of PCOS, ultrasound is the cornerstone. Now it is in the corner of a stone actually. So you remember like this, ultrasound is not the cornerstone, it is the corner of the stone, because we all know that ultrasound is not necessary for the diagnosis of PCOS. I will make it very simple. See, I have cut short everything. So the minimum investigation to diagnose PCOS. Okay. So you know that, you know LH, FSH is up. See here, BMI you take, waist circumference you take, Ferryman-Galway scoring system you can use, BP you take. Smoking is very dangerous. A PCOS woman with smoking will land up in cardiovascular diseases and MI. Oligo, and you have to counsel them properly. Oligoamenorrhea, FSH, LH, estradiol, prolactin and TFT, why do you take? To rule out other causes for menstrual irregularity. Then ultrasound, TVS, luteal phase, progesterone, if you just want to know that. But ultrasound is there to know that ovulation or not. Hirsutism, test-free testosterone, SHBG can be done. Obesity, if it is more than 25. Okay, if the BMI is more than 25 or 30. Okay, you do OGTT, lipid profile, and you can do HbA1c. This is the minimum investigation what you do. Insulin resistance. See, there are so many tests. You know that 60 to 70% of the population of PCOS have insulin resistance. All of you understood this much. So, you have so many tests are there, but don't bother anything. You do fasting blood sugar, OGTT, and HbA1c. So all of you remember to know the confirmed insulin resistance, you don't do anything else. Okay. Now, $1 million question. What is the role of AMH in diagnosis of PCOS? Okay. We all know there are multiple follicles. We all know that AMH level will be raised in PCOS. That doesn't mean that AMH level will be that much raised. So that is the importance of different phenotypes. Okay. That is why I told you the classical PCOS, phenotype A, the AMH level will be very high. There are PCOS phenotypes where AMH may not be raised also. Okay, so to ease it to differentiate. So from PCO like ovaries, from multicystic ovaries, if it is more than 28, okay, there is a sum. Otherwise, it cannot be used to say that AMH is raised, it is PCOS. You cannot tell like that. So there can be PCOS with, so this is a classical side. PCOS, AMH will be raised, but mostly in type 1 phenotype, the AMH, see, type 2, 8.6% only it is, patient only it is raised. So if it is so, this is what is important. We were talking, Dolly had come to us and we were telling so much theory. So she told that I don't want to listen to all these things. You come to matter. I want to only know how to go about it and what does my future hold. This is what I want to know. So the treatment strategies when you take, everybody knows here, there is no treatment for PCOS. We only treat the symptoms, not the disease. So we treat the symptoms and to prevent long-term health consequences, what is? So individualized target therapy as we do. So this is how in the adolescent period that as Dolly has come to you with irregular periods and features of hyperandrogenism. Next, in the reproductive period, she may come to us with infertility, recurrent pregnancy loss, GDM and PIH, and later she may come with metabolic syndrome and carcinoma endometrium. Now we will talk before telling you. See, you should know two words. All adolescent amenorrhea is not PCOS. This tell you a case. Okay. A 15-year-old girl, 11 years, had menarche at 11 years, period was irregular. Then she went for secondary amenorrhea. BMI was normal, no hirsutism, progesterone challenge was negative, high FSH and low AMH. So it's ovarian failure. Okay. So ultrasound shows small ovaries and occasional follicles. It's a Turner mosaic and POF. So any patient with amenorrhea and don't label it as POF, you remember such a. Another very important thing. See, I told you hyperandrogenism being the feature in an adolescent and all, but that doesn't mean always. Here is a case with 18-year-old girl, primary amenorrhea, Friedman, Galway scoring system more than 8. BMI 26, elevated DHEA, 17-hydroxyprogesterone and pelvic ultrasound was normal. Understood? Here it is a late onset congenital adrenal hyperplasia. Please remember this on one side. Any patient coming to you with severe hirsutism or if her LH, FSH, everything is normal, biochemical, then you have to do other investigations and if you see 17-hydroxyprogesterone and then you understood that it's a 21-hydroxylase deficiency, late onset congenital adrenal hyperplasia. So please, many times, once in a while, you will get this diagnosis and you will be able to treat that patient. Patient would have traveled in PCOS from one doctor to another. Unless you know this only, you will be able to treat. So, some differential diagnosis you all know now. You can know that late onset adrenal, congenital adrenal hyperplasia, Cushing syndrome, all these things are the other features which you have to. Now, the most important is weight reduction and exercise. Before that, just to tell you one theory point, PCOS insulin resistant obesity also increase insulin resistant, hyperinsulinemia leading to metabolic syndromes on one side. That means you have glucose intolerance, hypertension, hyperlipidemia, cardiovascular disease. On the other side, endocrine consequences like decreased LH, decreased SHBG, ovarian thick cell hypertrophy and ovulation. This is what is there. Now coming to most important and the most difficult thing. Diet control. This is the most difficult thing. If you see, eat plenty of cereals, pulses and millets, eat lots of vegetables and fruits, have enough of milk products, meat and meat products, and eat minimal of fatty foods, sweets, fast foods, fatty oils and sugars. This you remember. See, for everybody, because if you don't know, when the representative comes and tells you this is this something called dogma theory, this you have to know. Understood? This is now every treatment in every specialty is focusing on it. It's a role of gut microbiomes. This is, they are telling that all the disease in our body is due to this problem and they are bringing out newer and newer drugs. Okay. So what is it? Certain food tends to alter the microbiome leading to oxidative stress, inflammation leading to lifestyle diseases like PCOS. Okay. Processed food, artificial sweetener, alcohol, red meat, carbonated drinks all alter the gut microbiome. So green leafy vegetables, broccoli, cauliflower, fruits, all these things, probiotics, whatever we use like yogurt, naturally fermented food items, everything are gut friendly. Okay. So here, this is what is called dogma. So everybody remember this, any postgraduate sitting here, you should know dysbiosis of gut microbiota. See, you see that all fatty foods leading to leaky gut. It's called the leaky gut syndrome. So this leads to all the problems. You can see it can go from this gut, it can lead to insulin resistance and PCOS and all features of, this is what is called the dogma theory. So you eat, make it colorful and eat for your microbiome, colorful salads and all these things you have enough. See, we all tend to go for pharmacology. Obesity means immediately we try to, just wait. A PCOS patient comes with obesity, drugs are not the first for decreasing. So drugs should be considered as a first, not as a first line therapy in obese PCOS women. See, Orlistat and sibutramine can you use, but rimonabant is not approved. It is there in the market due to the high risk of serious psychiatric disorder. Don't take it for a long time. Prescribe it for a long time. So you know that associated with 30 to 60% of cases, usually android type, weight-hip ratio more than 0.85, increased weight circumference more than 90, insulin resistance. So next is diet is over. Next is exercise. Immediately they will ask you how to do exercise. Okay, the point is that 150 minutes you have to tell them. Better to tell 30 minutes per day. 30 minutes per day and walking, swimming, weightlifting, everything is very useful. So all of you say how much calorie can be? About 500 to 750 calorie decrease from your diet. That is what should be the instruction given. And minimum 150 per week, that minutes per week or 75 minutes of rigorous intensity, if it is a very rigorous. So many types of exercises are there. I am not going into the details. So the Dolly's future is now in a problem. Dolly, we are explaining menstruation, you have this problem. So infertility, miscarriage can occur, infertility, intolerance, all these things has to be counseled to her properly. And tell her that she has come with obesity. Tell her that even 7% of weight reduction lead to spontaneous resumption of menses. You don't have to do anything. So that is why first you try to decrease weight. Instead of giving drugs, decrease weight. Moderate physical activity should be the goal. What is a mode of action is that when you do good exercise and weight decreases, it lowers the circulating free androgen and insulin levels, increases SHBG level, thereby decreasing the free testosterone. Theory is simple. So, but to practice diet and exercise is the most important. So obesity is over. Next we come to the next important thing. Cycle irregularity. How will you manage? Okay. Journal of Clinical Endocrinology and Metabolism found that 79% menstrual irregularities. Another published journal of fertility and sterility later showed that PCOS 88% had menstrual irregularity. Another systematic review and meta-analysis for Journal of Human Reproduction Update shows that it's 75%. Almost 80% patients have menstrual irregularity. So before that, 4 types of patients present. All of you agree with it. See, women with PCOS may have fewer than 9 periods per year, may go more than 35 days period as we told. Okay, that is what is called an irregular, infrequent periods. Heavy prolonged periods. Patient may not have periods. When they come, they will have heavy bleeding. Okay, this is another way. Absence of periods. As initially oligomenorrhea, latest if you don't treat properly, it may lead to amenorrhea. Spotting between women with PCOS may experience. So, different types of presentation. You cannot say that PCOS presents like this. So, the patient you have may present in a different way. So, how do you treat this patient? Okay. So, the basic principle which you should have is that at least 4 menstrual cycles per year. So, at least she should, it doesn't mean that you have to menstruate every month. At least 4 periods in a year. You should not go for amenorrhea more than 3 months actually. So, start with cyclical progesterone, which is the simplest. 10 days, 10th, 14th day onwards, you start for 10 days. Medroxyprogesterone. Then you go, next is combined oral contraceptives, one of the best options. So we told how to handle a menstrual irregularity. If oligomenorrhea, amenorrhea does not respond to oral contraceptives, anti-androgen combination can be used. Then you can add insulin sensitizing drugs also. Lean PCOS may have insulin resistance, therefore they may not. See, we have a concept that lean PCOS means you don't have to give insulin sensitizing drugs. You may have to give even they don't respond. Now, which to give? What to give? Estrogen component of oral contraceptive, how does it act? Why do you want to give? It suppresses the luteinizing hormone and reduces the ovarian androgen production. Estrogen also enhances the SHBG level. We told that. That is why we start to stop OC pills, then only do the testosterone levels. Why? Because SHBG levels which increase the positive point. Cyproterone acetate, drosperinone and desogestrel are the three things which you use in combination. One by one we will take. Cyproterone acetate. Okay, it competitively inhibits testosterone, also 5-alpha dihydrotestosterone to androgen receptors it will act. Combination with ethinyl estradiol 0.35, cyproterone acetate 2 mg is the most scientific component. Whenever there is hyperandrogenicity, you give for 21 days. So, a patient with hirsute PCOS, the best drug is a combination of cyproterone acetate. Okay, drosperinone is ethinyl estradiol plus analog for spironolactone as a unique anti-mineralocorticoid and anti-androgenic property, if you know. So, and a combination of desogestrel is of. This is for an obese PCOS because it doesn't increase the weight and it is not as having complications as cyproterone acetate. I will tell you one small thing. One of my patients who was in Canada, she took cyproterone acetate 35 and she went combination and went to Canada. She was taking it. Actually, she came back by flight. Flight was about 48 hours she had to sit in the flight. Coming here, she had cough pain and she had DVT and finally she landed up in pulmonary embolism. Okay. After that, I am actually not afraid I am telling you. It is guidelines, certain things are written in the guidelines is correct. See, you have to be careful when you are using cyproterone acetate in long because these patients may be taking it for years actually. See, they have gone to Canada for studies. They will be taking it. They don't get there to get a doctor, to get an appointment is very difficult. So, they will be carrying 24 packets. And so, nowadays what I do when they do, I put them where stockings when they travel and all these things. I make sure even for OC pills I prescribe. After that pulmonary embolism, I am afraid actually. So, I had a very bad experience with that patient. So, that was the only thing that she was taking was cyproterone acetate combination for last 2.5 years what she was taking. Okay. There is role for insulin sensitizers. So many things. So, see, there are many schools of thought. Many people sitting here, I am sure that anybody who is not said, I don't use insulin sensitizers because the studies don't say. Actually, almost everyone sitting here uses insulin sensitizers, especially metformin. So, metformin, what is behind and whom to prescribe? You don't prescribe metformin for all the PCOS patients. So, it should be considered in women more than 25. So, more than 25 BMI is there. Metformin should be considered. Could be considered to adolescent with a clear diagnosis of PCOS and symptoms of PCOS before the diagnosis is made. And the metformin offers greater benefit of high metabolic risk groups, those with diabetes risk factors and impaired glucose tolerance. So, in general, all of you should understand that it's only 2 points. Whom to give metformin? PCOS, obese PCOS with abnormal GTT. Okay, all of you agree with it? Obese PCOS, if you ask, so it is a must. So there is no confusion. A obese PCOS come to you and your OGTT is abnormal, give metformin combined with. The problem of metformin is only gastrointestinal. That is always dose dependent. So start with a smaller dose. Start with 500, then you add to it. Like that it goes. Metformin use appears safe and it appears very safe. To long-term basis it appears safe. There are people who give metformin for every patient. See, I don't disagree with them. Every PCOS patient comes, you give metformin. There are people. They say they also have some reason for giving metformin for every patient. Difficult to predict which patient respond to metformin, so they better to give to everybody. Metformin has a direct effect on ovarian theca cell and decrease direct androgen production. And metformin inability accurately measure insulin sensitivity in all PCOS patients. They say that it's not possible. So I give to, metformin is not a drug which can cause complications too much. So why can't I give to all the patients? This is the theory, but you don't follow that theory. Go with the guidelines. You give to obese patients with the abnormal GTT, okay? And any patient who is not responding to your initial treatment, you can add metformin to it. Inositols, probiotics, vitamin D. What this evidence or what that guidelines say that inositol should currently be considered an experimental therapy in PCOS with emerging evidence on efficiency highlighting need to be further research. It's what the guidelines tells. None of us sitting here is going to believe that guidelines. Okay, that was in 2018. I have searched and found out new studies. See, the role of insulin sensitizers, so many things. See, every day, newer and newer molecules comes. Decoroinositol, inositol, melatonin combination, vitamin D combination, folic acid combination, omega-3 fatty acid combination. Newer and newer companies will be coming with. See, I always believe that something doesn't harm you. Using it is not a crime. Okay, but theoretically for the postgraduates, anybody sitting here, if you are asked in your exam, you say that, okay, there is no evidence for it. Latest, 2023. Latest study, you can see here, reproductive biology late, inositol is an effective and safe in polycystic syndrome, a systematic review and meta-analysis is there. See, non-inferiority, it's good. Vitamin D, see here, vitamin D is another study. Vitamin D is also, I know, I have an infertility specialist in Kerala, in all his prescriptions, vitamin D will be there. All, irrespective of everybody, vitamin D is there. So I called him one day, he's my student only. He's excellent, he is doing more than 150 cycles in 2 centers per month. So and excellent results also. So I taught him as my postgraduate, he was there going out, he's one of the busiest IVF specialists in Kerala. So I asked him, so I read nothing, what is wrong? Giving, and I am getting results. I am giving vitamin D to all patients. So vitamin D is another thing, doesn't give any harm, and these studies show that vitamin D is useful in many things, so nothing harm. Only thing, the cost factor, you always, when you add one after the another, think about your patient. Another thing is that probiotic and symbiotic, I told you, dogma. I told you the difference and I told you what is a dogma and what is a dysbiosis, and you have to know, because more and more products are coming, very costly. All these drugs are very costly. Now coming to looks matter. All of you knows that the looks matter. Patient comes to you, different types of patients. I'm not going to that case. Different, now we have the Dolly, which is hyperandrogenism. So principle is that, see, whenever a patient has hirsutism or acne, whatever it is, tell them that it's never completely curative and may need long-term treatment. Don't promise them 1 to 2 months you will correct it. Consider characters and expectations of the patient, and treatment should be monitored by an expert. Okay. See, OC pills for hirsutism. See, all the, anybody who can say, why we say Diane 35, Dinet 35. What is a 35? What is a 35? 24, we say 24 a day. But what is this 35? 35 is the dose of ethynyl estradiol. So it should be, see, always we use low dose pills. Low dose means anything less than 30. Okay, here you have to, when you are adding anti-androgen to it, you have to increase the dose of ethynyl estradiol. That is why anybody, all of you sitting here, should have, we write Diane 35, Diane 35. What is this 35? If somebody asks you, what is this 35? 35 is the dose of ethynyl estradiol. So ethynyl estradiol plus ciprofloxacin should not be considered as the first line. Please, everybody, first go with drospirenone combination. I told you, then only go with, if you are happy with drospirenone combination, don't have to go with ciprofloxacin at all, if you are able to get, because it has more complications with it. So I told you one complication which I had. See, not to frighten you, so that you know that drospirenone also has all this. It inhibits dihydrotestosterone, and it decreases inhibition itself. Hyperkeratosis, sebum hypersecretion and acne formation will be decreased. Ethyl estradiol decreases androgen and testosterone by inhibiting on the release and stimulation of SHBG synthesis in the liver. So this drospirenone combination, don't think that only if you add cyproterone you will get anti-androgenic effect. Drospirenone also has all these things. That is why I wanted to highlight. The same thing which I am again and again I am telling, if you are using anti-androgen, it should be the second. At least you should wait for 6 months using drospirenone combination. And this is the same thing which we have told. Okay, so the same things which I have told. See, should not be used as the first line. Almost all both the OC pills, similar efficiency, and lowest dose pills, like 30, should be used first. There it is. But you should all know, when there is excessive hair, only know, because the hair which has grown is not going to go with your medicine. So for that you have to do laser or epilation or whatever it is, you have to treat it. And you have topical, it's little costly. How many of you are using, I don't know, Efflora? So topical L-throxine cream is very costly. And you should, anybody can say when it is used? When, what time? What time of the day? It should be applied for 4 hours in the evening. Why? Because if you apply and go in line, hypersensitivity will happen. One of my patients applied in the morning, and when she came with, I thought fungal infection all over the face. Then I went to, then they told that it's all hypersensitivity to sunlight. So this is the best. See, we all know drugs. We all know the theory, but the practical points we don't know. When to use, what symbol? I told you, testosterone estimation, how do you do? This is another point. See, this is the practical points which you learn by listening to something. See, so you apply, ask it, it's also a good drug. Apply it and hair and all these things. You apply it on face. Ask them to apply 6 o'clock, 10 o'clock wash. Don't apply in the morning and go around, okay? Very costly, only give to patients who can afford. One tube costed 1,500, if it's applied, only 1 week will be over. Okay. So, So, see, we should know that, we should know how to use. See, whenever you are not able to control with metformin and your OC pill, then you have to go for add spironolactone or finasteride, okay? I give spironolactone actually, the combination I give, but you have to be very careful. Electrolytes and all these things has to be checked. Don't give spironolactone and send the patient. Only give to people who can follow up. Finasteride is another simple drug, that is also a good drug. See, when you know that, see, most of the drugs acts at only 2 positions. If you want to decrease testosterone, it is simple. Dihydrotestosterone is the active form. So the enzyme converting testosterone to dihydrotestosterone is 5-alpha reductase. Either the drug acts on 5-alpha reductase or the drug will act on the receptor. Cyproterone acetate acts on the receptor. Finasteride acts on the 5 and spironolactone acts on the 5-alpha reductase. Okay, so see, things are simple actually. So unless you know the little theory, you should know, that is what, then your practice becomes very easy. So this is what you have to monitor. See, cyproterone, finasteride and all these things given, potassium and renal function has to be monitored at 6 to 12 months interval in a long-term use. Okay. So a patient has hirsutism. She wants infertility. Don't touch at all with anti-androgenic drugs. You treat infertility. Okay. If she is no infertility concern, ask her any contraindication of OC pills, otherwise OC pills are the best. If she has no contraindication of OC pills containing cyproterone acetate or drospirenone can be used. If it is not required, then add finasteride and spironolactone. Very simple. If the patient has any problem with OC pills, don't use OC pills at all. Directly go for spironolactone, cyproterone acetate. You understood how you treat a hirsutism. Okay, how you go about with hirsutism. So you have to think on other. So exclude potentially serious causes of appropriate and all these things which what we told as at least you should give it for 12 months. Okay, and you can, in obese cases, you add metformin to it. So metformin also gives you advantage. Coming to the cosmetic treatment, acne. So I told you acne may require oral antibiotic like erythromycin and isotretinoin ointment. So please see that isotretinoin should not be used in pregnancy. Okay, see, please, even a topical preparation is dangerous. So please don't, patient comes with acne in pregnancy, don't use all these things. Tell them that after pregnancy, delivery, we will care. So use of oral contraceptive pills along with, see, best is cyproterone containing. Along with, you can use erythromycin and creams, it will act. And you should understand that, see, impact on acne on PCOS. See, different studies have shown that patient depression, anxiety, all these things are there. Don't think that looks matter. For a patient, it may be the menstrual irregularity may not be their major concern. Acne and hirsutism, and don't take it lightly, treat them. So, combined oral contraceptives are superior to the treatment. For summarizing, treatment of hirsutism and acne compared to progesterone-only preparation. Metformin-only therapy exerts mild to moderate cycle. See, only giving metformin in cycle irregularity is useless. You have to use OC pills plus metformin. Just giving metformin doesn't clear the cycles. Encourage combining metformin plus OC pills in overweight. There is no evidence in one type of oral contraceptive better than other, what we told. Now, our patient Dolly is getting married. Okay, she has become Mrs. Dolly. But the problem is that every problem is there. She doesn't want to become pregnant now. She told that high BMI, hirsutism, acne, oligomenorrhea, everything is there. She is continuing with the treatment. So, best is she needs contraception also. Best is drospirenone containing pill followed by cyproterone containing pill or desogestrel can be used. Advantages are she gets cycle regulation, effective contraception, no weight gain and control of androgenic symptoms. Our Dolly is happy. Then after 2-3 years, Dolly thinks that, okay, I want to become pregnant. She is trying for pregnancy and she is not becoming pregnant. As she is obese, not only all of you should listen to one thing, just by giving an ovulation induction, no use. Along with that, you have to give weight reduction. Even with just a weight reduction, she may become pregnant. Okay. So, ovulation induction, just giving, come on, you have just start ovulation induction and our treatment. So, plus, but for a lean PCOS, ovulation induction may be enough, but you have to ask them to do exercise. So, one patient last week when she came, it's a young lady, she's not obese at all. So, when I told to do exercise, why should I do exercise? I am only, so the muscle mass, the bone mass. So that is important. So the exercise should be done by obese PCOS as well as lean PCOS. Confusion, letrozole, clomiphene. Now we all use letrozole. There was a time when letrozole was not there, we were using clomiphene. So the advantage of letrozole, in short, we know that it doesn't affect the endometrium and the multiple follicles are not there and OHSS chances are less. So everything advantage for letrozole. So there are so many systematic reviews and all these things. Finally, everybody concluded first line therapy for ovulation induction in PCOS is letrozole. Okay, letrozole. So, different ways of giving 2.55. These are different ways of giving letrozole for ovulation induction. Now, the problem is that with letrozole, patient is not ovulating. So, what will we do? The same thing. You can give letrozole 2.5 for 10 days. Or you can give letrozole, they tried. 5 milligram for 10 days you give. Extended letrozole, then also the patient is not ovulating. This is one drug which was used during the time when letrozole was not there. Okay, we used to use this drug when the clomiphene was resistant. No other way was there. We used to use tamoxifen. So, in a way, see, it's a jiggling. The patient to ovulate, you use different types of combinations. Infertility specialist sitting here, there are now studies coming using letrozole and clomiphene together. Do you know? Theoretically, it doesn't join together. But if you go through the fertility, sterility studies, there are studies coming with letrozole and clomiphene together. It is not ovulating with letrozole, we give clomiphene with letrozole together. Okay, so these different types of combinations are. So when it's they can use even tamoxifen can be used. Add metformin, come on. Whenever it is not responding, you add metformin, especially in a obese, more than BMI is more than 25. Please add metformin. It will respond, letrozole will respond. So combining metformin with letrozole, metformin could be used before and during FSH for FSH stimulation in women with PCOS undergoing ART with gonadotropin releasing hormone agonist protocol. So, see, insulin resistance is widely prevalent. It has been told in Indian population, it is, you see, 76.9% PCOS women have insulin resistance. That is why the metformin has a role. So, different types of combination. This is just my slide. Okay, different types of combinations I have kept. Myo-inositol can be added, myo-inositol, decaro-inositol can be added, inositol for metformin. So, this is something I do. Say if it was a lean PCOS, I give myo-inositol. Adolescent PCOS, I give myo-inositol. In the ovulation induction with PCOS, I can add. PCOS with GDM risk, I add because it's an insulin sensitizer. Myo-inositol, decaro-inositol combination, obese and infertile, it becomes acts better. Metformin combination also is there. Different types of combinations are there. So basically it is nothing. You give letrozole, not responding. Add to letrozole, increase the dose of letrozole, not responding, add metformin to it or any insulin sensitizer. Metformin plus one insulin sensitizer to it. This is what it's going. Then also, this is another thing which I follow. All the infertility top people will be using it for the others. We can also use it. I am not doing, I will doing only till IUI. I don't do IVF, but I know things I send to, because too much work in so I cannot do IVF, so my friend does IVF for me. So here I add dexamethasone. So it suppresses adrenal androgen production, create better response to clomiphene or letrozole in PCOS with high androgen levels and elevated DHEAS levels. Suggested is 0.5 milligram daily from day 1 to 14 together with clomiphene. It better acts, it's a steady, so you can use with letrozole also, but it acts better with clomiphene. So madam, senior madam that you will be using, dexamethasone, all IVF people, they will use. So we can also use, there's nothing wrong in using it. Gonadotropin stimulation. Which gonadotropin is the best? We don't know. Okay, there are so many things. You can use HMG, you can use purified FSH, you can use highly purified FSH, you can use recombinant gonadotropins, you can use anything. Depending upon, see if your patient is poor, you use HMG. But FSH step-up protocol, you slowly increase. In each cycle you increase and see. That is the best way. That is what ASRM recommendations also. Step-up protocol and they use FSH is the best. That is what is recommended. Previously there was a saying that, see, LH is already high. So that has gone actually. Don't believe that. LH is already high, so don't use LH, HMG. You use only FSH. No, we should not use. That is gone. Now HMG as well as pure FSH, separate FSH has almost a similar results when you are not getting, because the cheapness is there. So your patients will be cheap, but IVF patients, so this is the combination. Letrozole, then FSH, letrozole, FSH together, different ways of giving it. The question one of the last few slides, the question which you always arise, how many cycles of ovulation induction you will do before you send to madam? Before you send to all infertility IVF specialists or top IVF specialists in your Solapur is there, before sending to them, you all do infertility, but suffering the patient when you will do. So we should be careful actually. In at a stretch 3 cycles. Total 5 to 6 cycles of ovulation using oral agents. 12 cycles of ovulation induction lifetime. If you are not getting, send to your neighbor. Don't play with your patient. So you have weight reduction, letrozole, gonadotropin, laparoscopic ovarian drilling or IVF. This is just to show insulin sensitizers and all these things. So 10 commandments, what I say is that diagnose correctly, do not over-investigate. Okay, in an infertility, do not do so many tests to diagnose PCOS. Remember lifestyle. Lifestyle is the most important. Letrozole is the best friend. Gonadotropin need use, judicious use. Whenever you are using in PCOS, be careful. Think in your mind of OHSS. Okay, all of you, because this is the patients in which once, see, if you have good IVF centers, they write OHSS free clinic and all these things. See, they know that this is, once you land up with OHSS, I am a referral center. I get patients from IVF centers with OHSS with full of, so when we ask them, Do you know how much FSH and all these things, HMG and 225 was the dose last month. One patient was a very bad state. So she was given maybe there will be normal for all of them. So, but you can use any dose. But you have to judiciously monitor it. Not that it is not responding with 150, you have to step up. You have to give 225. So, but you can use, but be careful. Okay. So, IVF for a few. So, see, never say that PCOS I will not send for IVF. There are PCOS patients requiring IVF. So, don't say that, you be stringent that. What about your many laparoscopic young surgeons are there? What about your laparoscopic ovarian drilling? Now it has actually gone out of, but could be the second line of therapy who are clomiphene or letrous ovulation does not occur with drugs. It is another option, par to gonadotropins. Okay, cost is there, you have to be expertise, you should not damage, but there are intraoperative and postoperative risk. Who are overweight and obese, the risk is there, and there is risk of lowering ovarian reserve. See, many times you send after drilling and to IVF center. IVF becomes negative. First thing what you do, what the IVF person, not to blame anybody here. Some of the IVF people blame the surgeon who has sent, telling that she has damaged your ovary, punctured it and damaged, that is why everything is the problem. So, laparoscopy ovarian drilling, I want to tell you a small point is that in clomiphene resistant or resistant to slim, see, it's contrary. Metformin in obese patient, laparoscopic ovarian, better results you get in a thin PCO. So, you see all these things. Thin PCOs are difficult to manage. Obese PCOs are easy to manage. If you ask me, which you want? A obese PCO, I've always wanted an obese PCO. Because when the weight reduction, you will easy to manage. Thin PCO is very difficult to manage. Even they land up in... now, coming to the last 2-3 slides. Dolly has become pregnant. Oh, we want all efforts of our infertility specialist. Finally, Dolly has become pregnant. But Dolly should understand that she can have miscarriage, she can have cervical insufficiency, she can have gestational diabetes, hypertension, preterm labor. And see, there is an IVF center near IVF person. Every PCOS patient, actually, he sends to me for cerclage. Maybe he had some bad experience. So I tell him that what you are doing, Ashwath, you do cerclage and send back. I don't do, you just do cerclage and send back to me. I don't want to listen. So I told that there is no indication to it. So there is an association with PCO and cervical incompetence. Doesn't mean that you have to do cerclage at all. So hypertensive, preterm labor and FGR as well as intrauterine fetal death. So problems, she can have a preterm delivery, twofold increase in preterm delivery, meconium aspiration syndrome. Always listen to all these things. So be careful. See, monitor her. Don't do prophylactic cerclage. Monitor her. If the cervical length becomes less, you do a cerclage. Preterm labor, meconium aspiration. There is SGA. There is increased risk of small 4 gestational age in non-obese fertile. PCOS who are non-obese has SGA, and PCOS who are obese has large 4-date baby. So they can have both. PCOS can have both. Now she delivered. She has a baby now. Now she is asking, Dolly is asking, has come for what should I do now? Spacing. I don't want now. So after 1 year, she is telling, no, I don't want children for next 3 years. Now we go back to, we have enough drugs in our hand. We have drospirenone containing drugs is there. Or we can go to, if she is having hirsutism and all, we can go to. Now after 3 years, Dolly is again in front of you, telling that now I want one more baby. I am trying and I am not. So the same cycle is being repeated. We do all the drug ovulation induction, obesity, weight reduction, management, add metformin, insulin sensitizer. Not responding, we go for gonadotropins. Finally, we send the patient for IVF and she completed her family. Okay, she completed. Dolly is now happy with her family, with 2 children. Dolly is happy now. Now, Dolly again has trouble. Irregular period once again, periods of amenorrhea, obesity, lethargy, again acne, everything again starts. She is 30-35 years, but all these problems continues. Again, all these problems we charge a protein rate, we have to follow up her properly. Perimenopausal ladies, androgen excess, diabetes is 7 times high in this patient. Hypertension is 4 times high. We have to, metabolic syndromes are cardiovascular accidents, endometrial cancer. Everything is more. So, How do you define a metabolic syndrome? You should know, just telling that, okay, this patient is having metabolic syndrome. Only that 3 of the 4, 5 criteria, all of you listen to it. Central obesity, that the weight circumference more than 90. You remember 90 is easy. 90 triglycerides more than 150, HDL less than 50, hypertension, fasting as well as GTT is high. Hope that if 3 or more is there, of this 5, 3 or more is there, then you label this patient as what? Metabolic syndrome. Okay. So, treatment of metabolic syndrome, lifestyle changes, diet, I told you, low fat diet, high fiber, low glycemic index, addition to insulin sensitizers have helped to reduce. So, here the role of insulin sensitizer comes. You can use without any problem. Give some insulin sensitizer, give them vitamin D regularly. Okay, all these things can be done. That to extend, high-risk patients can be given metformin. Metformin is not a drug that is contraindicated. You can give, whenever it's a metabolic syndrome risk is there, give them prophylactic metformin. Prophylactic metformin can be given, but other things should not be given because it has all complications are there. But you should do OGTT initially and every 2 years. So whenever the OGTT is abnormal, put the patient on metformin. Even if FPS and all these things are normal, don't believe, you put the patient on metformin and let her take metformin for lifelong. Metformin to prevent, impaired glucose tolerance, even PCOS with family history of diabetes. So in which all patients you give prophylactically metformin? Impaired glucose is there or a family history of diabetes is there, it's obese and she's not able to lose weight. Continue metformin. So, and risk factors are there, which I told you, you should give metformin to the patient. This is what. Cardiovascular disease, stop smoking, diet, exercise, lipid profile initially and every 2 years. And I give rosuvastatin 5 milligram prophylactically. Okay. Some people give even ASA. Aspirin is also given to the patient. Prophylaxis, unless they land up in some complication, better than that, you give. So whenever there is lipid profile is abnormal and all these things, statins, you ask them to exercise and nothing wrong in giving statin for a long time. Prevention, so statins may be recommended in PCOS who have high cholesterol levels. So any PCOS, so same thing. Any PCOS patient with abnormal GTT, you will give lifelong metformin. Any PCOS patient with abnormal lipid profile, you give statins. And aspirin can be also recommended. LNG-IUS, very good. So whenever there is endometrial hyperplasia, family is completed, put an LNG-IUS. So it will prevent endometrial malignancy. So always it's a prevention is better than cure. All long-term complications in menopause, imagine. Now Dolly is having so many problems now. But one thing, maybe it is the last slide actually. It is the last but one slide. The most important in PCOS is counseling. Unless you are not able to a good counselor, PCOS means you have to spend time with the patient. So please, all of you, I put it as the last slide because I want to say that without counseling, first time the patient comes itself, you have to start counseling. So psychological support, lifetime and everything, and future counseling also has to be done. PCOS is something like Jeevan Barka Sati. So it is nothing and it has to be there. Once you diagnose PCOS, it has to be there. To conclude, chronic diseases manifest across the lifespan, represent a major health and economic burden. Differential diagnosis criteria, but Rotterdam is widely used. Management aim to ameliorate symptoms, prevent long-term morbidities with strong emphasis on lifetime management, targeted medical therapy. To conclude, enigmatic, lesser understood, diagnosis can be tricky, management is age and need oriented, life modification, fertility can be difficult, and prevention of long keep in mind. So, Dolly into the tomb as I descend. Look forward for a magical drug, supplement or an adjuvant. The enigmatic PCOS to prevent. Women in all age group, may they never lament. Dear all, do try to invent. Godspeed. That is what. Thank you so much for a patient listening. Hope that out of the way, hope that you all the latest evidence and guidelines has been, take some points out of it after hearing an oration going back. Some 1 or 2 points, if you learn itself, is something like the new classification, phenotypes, all these things. What is FNPO 20, adolescent, don't need testosterone, how do you estimate it should be done properly? All small, and dogma, the other theory which I told, lifestyle modification theory which I told, all adding insulin and about insulin sensitizers, all these things, and so many things are there. So all these things, adding metformin, adding insulin sensitizer, long-term statins, all the small points if you take from it will help you in your practice. So all the latest guidelines and what we mean, thought of oration is that whenever I go and give oration, I do see all the guidelines which is because we are all busy practitioners. So from attending all these things, only myself also, I attend all these things when Milan sir gives oration or they all come. So when we listen to it, we get small points out of it. So it's a whole thing which so I hope that you are satisfied with what our things are. Thank you so much. Thank you for inviting me. It was a pleasure to be with you.
Thank you, sir, for this mesmerizing story of Dolly from womb to tomb. We are really lucky to have you here. Thank you. I think sir deserves standing ovation for him. Thank you very much.
Thank you, sir. I request Dr. Anjali Jamma ma'am and Dr. Manik Gurram sir to honor and felicitate Dr. Ashwath Kumar sir with silver plaque and citation. I request Dr. Archana, Dr. Monica to please join on stage.
Obstetrics and Gynecological Society is honored to present late Dr. V.N. Shirodkar Oration Award to Dr. Ashwath Kumar for his outstanding contribution in the field of gynecology. Sunday, 9th April 2023. Dr. Anjali Jamma, President. Dr. Archana Khare, Honorary Secretary. Thank you.
Thank you. Madam, come, madam.
Adi Oration. Yeah. The Solapur Obstetrics and Gynecological Society, the President, office bearers, and members of the Executive Committee of the Solapur Obstetrics and Gynecological Society are pleased to present the late Dr. V.N. Shirodkar Oration 2023 to Dr. Ashwath Kumar, Trishur, Kerala on 9th April 2023. Sir, you are professor at the Department of Gynecology at the prestigious Jubilee Mission Medical College at Trishur, Kerala. Your academic qualifications received from various parts of the world truly exemplify your proficiency and love towards laparoscopic surgery. Along with being an astute surgeon, you are a popular teacher, loving husband, and doting father. You are not only an excellent academician, but also a man of multiple virtues. Your fandom for football is contagious, and your table tennis skills are superb. You are an excellent artist and a wonderful guitarist too. You are the recipient of many prestigious awards, namely the DC Datta Award for the Best Publication, the SC Dawn Prize for the best presentation at AICOG, the Siuli Rudra Sinha Prize for the best paper in endoscopy at AICOG Patta, and the Pride of Foxy Award. You have proficiently served the Vice President of Foxy and are currently shouldering the responsibility of President of KFOG. You have also been a member of important committees at various organizations like ICOG Governing Council, IIG Managing Committee member, and Foxy Quiz Committee chairperson. You have authored many books and have multiple publications in national and international journals to your credit. You have delivered 10 orations and given over 200 faculty presentations, and have also been an operating faculty at various national and international conferences. True to your name, Ashwath, you are indeed a tree of knowledge. We value your passion for sharing your knowledge and experience. In appreciation of your achievements in the field of obstetrics and gynecology, we consider it an honor and privilege to present to you today the prestigious late Dr. V.N. Shirodkar Oration Award 2023. Your oration from womb to tomb, the story of life with PCOS, has enlightened us. Dr. Anjali Jamma, President, Dr. Archana Khare, Honorary Secretary, Dr. Supriya Jadhav, Clinical Secretary, Dr. Monica Umbadan, Honorary Treasurer. Thank you, sir.
Thank you, sir. Thank you. Thank you, sir. Thank you, sir. Check the time. I will check the time.
Now I request Dr. Vivek Virkar sir to please felicitate our chairpersons for this oration.
Pratibha want to say few words.
Asam Sakal, sir. Asam Sakal means Namaste in Malayalam. Respected late Dr. V.N. Shirodkar oration today by Dr. Ashwath Kumar sir से आज हमें ये हुआ है साक्षात्कार कि PCOS के फिनोटाइप्स 4 होते हैं प्रकार. नया लीकी गट और डॉगमा थ्योरी से हमारा कराया परिचय. कहा खाने के प्लेट्स में कलर का करो निश्चय. एक्सरसाइज भी है उतनी ही महत्वपूर्ण. अगर नहीं किया तो ट्रीटमेंट में कंट्रीब्यूशन होगा शून्य. हाइपर एंड्रोजनिज्म को ड्रोस्पेरिनोन या फिर सावधानी से सिप्रोट्रोन एस्टेट से करना है टैकल. साइकिलिंग स्विमिंग ऐड करके कमर के बेल्ट का कम करना है बकल. इंसुलिन रेजिस्टेंस के लिए मेटफॉर्मिन दीजिए. आइनोसिटॉल प्लस डी कैरोनिस्टॉल यूज को लेकिन पिंच ऑफ सॉल्ट के साथ लीजिए. विटामिन डी यूज़ करने में नहीं है कुछ हार्म. अगर इनफर्टिलिटी पेशेंट कंसीव कर जाती तो मिलेगा ही आपको. समरी यही है कि हर यूएसजी में ज़्यादा फॉलिकल्स दिखने पर नहीं करना है लेबल PCOS. FNPO यानी फॉलिकल नंबर पर ओवरी मोर देन 20 होना चाहिए और ओवेरियन वॉल्यूम मोर देन 10 cc तो ही सोचो PCOS. डॉक्टर अश्वथ कुमार जी, आज आपका धन्यवाद करते हैं हम बार बार. पीसीओएस डॉली की कहानी हमें सुनाई इस इतवार। याद रखेंगे ये टीचिंग्स हमें। आपको फ्यूचर के लिए लख लख शुभेच्छा। थैंक यू।
Thank you everyone. With the permission of chair, I declare the oration ends here and I invite you all for the lunch.